السلام عليكم ورحمة الله وبركاته. أنا دكتورة شيماء رفاعي, Assistant Professor of Pediatric Endocrinology and Diabetes, Tanta University, and the Head of Pediatric Endocrinology and Diabetes Unit. أحب في الأول أشكر دكتور أشرف الشرقاوي على دعوتنا لمؤتمر المنصورة, وكالعادة إن شاء الله مؤتمر موفق. أنا النهاردة إن شاء الله هكلمكم على الثيرويد سيكريتس. طبعا إحنا عارفين إن الثيرويد جلاند دي مسؤولة عن حاجات كتيرة جدا في البادي. عشان نتكلم عن الثيرويد سيكريتس كلها محتاجين مؤتمر منفصل يعني لوحده عن الثيرويد. فأنا هتكلم تقريبا على معظم الحاجات اللي ريليتد للهايبوثايروديزم. بداية كده, الهايبوثايروديزم is commonly diagnosed endocrine disorder. Typical signs and symptoms of hypothyroidism زي مثلا weight gain, inability to lose weight, easy fatigability, constipation, hormonal disturbance, ممكن كمان muscle pain, poor concentration. كل الحاجات ديت common signs اللي احنا عارفينها عن الهايبوثايروديزم. However, some patients may present with unusual signs and symptoms of hypothyroidism, which can result in diagnostic confusion. الحقيقة confusion ده بيأثر على اللايف ستايل of the patient. طيب كده ممكن نسأل نفسنا ايه هي weird symptoms of hypothyroidism you might be missing؟ ايه هي ممكن تكون manifestations دي؟ أنا هلخصها كده في case presentations. هناخد 4 cases, كل كيس فيهم مختلفة عن التانية, وهنلاقي إن الكوزز فيها تكون الهايبوثايروديزم. Case number 1, an 8-year-old male child present with complaints of growth failure, short stature يعني, easy fatigability, deafness for 1 year. He also gave history suggestive of proximal muscle weakness and hair loss. No other members of the family was affected. Anthropometric measurements of this patient showed overweight and short stature. On examination, heart rate was 60 beats per minute, bradycardia, regular, all peripheral pulsations are palpable, blood pressure was normal, and sometimes the patient was hypotensive. Coarse facial features, depressed nasal bridge, facial and periorbital edema of roughness, and dry skin. Bilateral calf muscle showed bilateral bulky calf muscles with delayed contraction and relaxation of the ankle jerks. Pseudomyotonia of calf muscles with negative Gowers sign. ده كده البيشنت بتاعنا اهو. في manifestations of pseudo hypertrophy في upper and lower limbs. Routine investigations of this patient were normal, and thyroid functions was done for this patient, showed low FT4 and high TSH level. This patient was diagnosed as severe primary hypothyroidism. Other investigations done for this patient, audiometry, لأن البيشنت ده كان عنده conductive deafness since 1 year. EMG showed myopathic pattern changes. Hemoglobin level was 9.4. البيشنت ده كان بياخد treatment for resistant anemia for more than 1.5 years without response. Primary autoimmune etiology was confirmed by raised antibodies titer. Serum creatinine kinase was elevated. Ultrasound of the thyroid gland showed diffuse thyroid enlargement. لو جمعنا كده الكرايتيريا اللي موجودة في البيشنت ده, عنده hypothyroidism, pseudo hypertrophy of the muscles upper and lower limbs, and elevated CPK. دي الكرايتيريا بتمشي مع الكوكر ديبر سيملين سندروم, والبيشنت ده كمان كان EMG بتاعه affected. ايه هي بقى الكوكر ديبر سيملين سندروم؟ دي بتحصل فيها سودو هايبرتروفي في المسلز نتيجة accumulation of glycogen and other mucopolysaccharides in the muscles. نتيجة impairment of the carbohydrate metabolism resulted from hypothyroidism, long-standing طبعا and neglected hypothyroidism. الديفنس اللي كان موجود مع البيشنت طبعا corrected برضو عن طريق ان هو wearing aids. في بعض الحالات مش لازم تكون اوتو اميون هايبوثايروديزم، لا ممكن يكون الكوز فيها congenital hypothyroidism. This patient was treated with L-Droxin once daily طبعا. On follow-up after 3 months, he showed significant improvement in symptoms and signs of thyroid deficiency, and thyroid functions test regressed to normal after 3 months. Thyroid functions كانت TSH بتاعته 2.5 after being 250. كمان الفوليوم of the calf muscles حصل فيه regression nearly to normal. ده بعد 3 months of treatment and the patient doesn't receive any treatment except for L-Tox. Case number 2, 16 years old female presented with gradually progressive swelling over her legs over 3 months with attacks of blurring of vision. This swelling had no diurnal or postural variation, and it didn't respond to diuretics previously prescribed to her. In addition, she had gained 5 kilograms since 1 year, associated with malaise, fatigue, and intolerance to cold. No family history of chronic illness or thyroid disorders. So this female patient had a gradually progressive swelling of her lower limbs with blurring of vision. On examination, her skin was dry, scaly, heart rate bradycardia. Her eyes were slightly protruding with normal conjunctiva and goiter. Bilateral non-beating edema was noticed below her knees. دي طبعا البيكتشر بتاعت الاوفثالموباثي اللي كان موجود عند البيشنت دي. Thyroid functions of this patient showed a low FT4 and elevated TSH level, so it was diagnosed as a primary hypothyroidism. Primary autoimmune etiology was confirmed by raised antibodies titer. Ultrasound of the thyroid gland showed diffuse enlargement of thyroid lobes with increased vascularity. طبعا اتعمل لها كمان fundus examination عشان البيشنت دي كانت complaining mainly of blurring of vision. كان normal. The patient was diagnosed as hypothyroidism ophthalmopathy. والاوفثالموباثي مش لازم يكون موجود مع الهايبرثايروديزم زي ما هو معروف، لا في حالات كمان بتبقى مع الهايبوثايروديزم نتيجه الاكتيفيتي اوف انتي بوديز على المسلز الاوكيولار مسلز. This patient received only treatment for hypothyroidism in the form of L-Droxin in dosage of 1.6 microgram per kg body weight. Over the last 6 months, she showed gradual regression of pedal edema اللي هي كانت النون-beating edema اللي موجودة عند البيشنت دي وكمان الأوفثالموباثي. البيشنت دي برضو doesn't receive any treatment except for L-Droxin. Case number 3, 14 years old female presented with history of bilateral breast tenderness and discharge. She had a history of generalized headache of 6 months duration and easy fatigability. She had developed diplopia and diminution of vision over the previous 20 days. طبعا أول ما بنشوف breast discharge بنفكر على طول في البرولاكتين ليفل. Routine investigations of this patient were normal except for low hemoglobin level 6.4 جرام per deciliter. طبعا معظم الحالات بتاعة الهايبوثايروديزم بيبقى معاها normal نورموسيتيك نورموكروميك انيميا. علشان كده البيشنتس دول دايما نلاقيهم عندهم ريزيستنت انيميا، وللاسف معظمهم بيبقوا treated with iron supplementation without response، وهم مش المفروض ان هم ياخدوا iron. The TSH of this patient was above 300 microgram and low T4 and T3 levels, positive antibodies also, and high prolactin level. في الحالة دي برضو البيشنت diagnosed as autoimmune hypothyroidism with high levels of prolactin. ده معناها ان انا عندي مشكلة في البيتيوتري جلاند. المشكلة اللي بتبقى في البيتيوتري جلاند ان انا كل ما زاد عندي TSH كل ما اشتغل على الثايروتروبس and prolactin secreting cells، لان هو عنده molecular mimicry مع البرولاكتين، فبيشتغل كستيميوليشن للبرولاكتين، بيتفرز البرولاكتين اكتر. الفيجوال field of this patient showed bilateral diminution and multiple areas of scotoma. So what's next for this patient? Patient عندها hypothyroidism with elevated prolactin level and blurring of vision with multiple scotoma and impairment of visual field. عملنا MRI pituitary للبيشنت دي showed right hemi pituitary perfusion defect mostly microadenoma. طبعا المايكرو ادينوما في الحالات ديت ما بتحتاجش اي سيرجيكال كونسلتيشن او اي سيرجيكال انترفنشن، برضه اتعمل لها نيو سيرجيكال كونسلتيشن and follow up was recommended. Patient D was diagnosed as pituitary hyperplasia and pseudotumor cerebri due to primary hypothyroidism. Patient D كان عندها manifestations of hypothyroidism, hyperprolactinemia, blurring of vision من البيتيوتري hyperplasia. برضو أخذت treatment in the form of L-troxin only. Prolactin level falls without treatment except for L-troxin to normal after 2 months. Follow-up of MRI as recommended by neurosurgery, followed by every 6 months, and showed regression of the pituitary size. ده كده after treatment with the patient with reduction of the size of the tumor and also improvement of the visual field without areas of scotoma. طبعا في حالات كتير جدا بتبقى recorded من البيتيوتري hyperplasia مع السيفير primary hypothyroidism بالذات اللي neglected. Pituitary hyperplasia دي mainly due to primary hypothyroidism. لو ان الانسيدنس بتاعتها is not low، بالعكس ان الانسيدنس of pituitary hyperplasia in patients with hypothyroidism varies from 25% up to 81%. With high incidence is reported with patient with TSH level more than 50. واحنا هنا البيشنت عندنا اصلا كان TSH بتاعها اعلى من كده بكتير. عشان كده الحالات اللي بتبقى جايه ودايجنوزد بالهايبوثايروديزم لازم نعمل لها fundus examination even if the patient is not complaining. Case number 4 ودي last case. Female patient with Down syndrome, 16 years old, presented with dyspnea, cough, easy fatigability, no history of any medical diseases. She sought medical advice and ordered X-ray. X-ray was done showing cardiomegaly or increasing the cardiac shadow. في البيشنتس بتوع الداون سندروم عادة يعني لما بيجوا بديزنيا وكاف we expecting bronchopneumonia or chest infection. لو كانوا عاملين cardiac operations بنشوف في complications cardiac ولا لا. The echo of this patient was done showing pericardial effusion with normal cardiac functions followed by pericardiocentesis. ECG was done showing low voltage QRS complex. On examination of these patients, vital signs were normal. facial examination طبعا غير ان هي down facial كان فيها periorbital edema. Heart examination showed distant heart sounds. Chest examination was normal, and lower limb, there was no lower limb edema. The patient, this is our patient اللي هي Down syndrome وفيها periorbital edema وفيها كمان dry skin and thick. Investigations for this patient showed low FT4, elevated TSH level. This patient was diagnosed as Down syndrome with primary hypothyroidism. طبعا في حالات الداون since birth and follow-up of these patients لازم بنعمل الثيرويد functions even لو كانت normal at the start. طبعا البيشنت دي was neglected up to إن هي جالها precordial effusion. برضه الانتيبوديز in this patient was elevated. A thyroid ultrasound shows diffuse enlargement of the thyroid with increased vascularity. طبعا مش كل الحالات بتاعة الداون بيبقوا autoimmune، ممكن يبقوا diagnosed since birth with congenital hypothyroidism وبرضه يحصل معاهم pericardial effusion. في الحالة دي احنا شخصنا ان الحالة دي pericardial effusion due to autoimmune hypothyroidism after exclusion of all causes of pericardial effusion in Down syndrome. طبعا احنا كده اتكلمنا على 4 cases or 4 presentations unusual symptoms of hypothyroidism. حاجات احنا ك endocrinologist مش متعودين ان احنا بنشوفها كل يوم. في حاجات منهم case reports بس موجودة و should be kept in mind. في حالات تانية مثلا زي حالات البي سي او regular menstruation، كل الحالات دي بيبقى فيها hypothyroidism. في حالات بيبقى فيها انكفالوباثي نتيجة الهايبوثايروديزم. فالثيرويد دي لازم تتحط في mostly all diseases with atypical presentations. So take home message, besides the usual clinical manifestations of primary hypothyroidism, there are others that are very unusual and hence are not easily recognized by the treating physician. The timing of identification of these manifestations of these atypical presentations is very important for early intervention and the treatment of hypothyroidism. Thank you.